Good morning. Thanks for joining us, guys. So the way we're going to run through it today is we're going to have a short session on x-ray, then we're going to move to transesophageal echo, and then we're going to finish up with some CT scan, and then we'll throw out some random films to see if you guys can retain some of the knowledge we talked through this morning, and also I'll be happy to entertain any questions. So x-ray is oftentimes underutilized and dismissed these days in the advent of CT scan, MRI, PET scan, etc. Some of the more fancy modalities that are out there. But a plain x-ray can tell you a whole lot of information. It's cheap, it's low risk to the patient, and it's readily attainable anywhere, even at the bedside, so you don't have to transport patients really at all. So when you look at an x-ray, you really have to be concerned about what am I looking at? And I go through the same process every time I look at an x-ray. There are certain things that I go through, there's a certain order that I go through them in, and they each have their own reason. So the first thing I do is I always check to make sure it's the right patient. Many times you get the x-rays loaded up wrong or incorrectly, or the nurse in the room at the bedside, or even the nurse in the operating room has the wrong patient pulled up. And so that obviously could be catastrophic. So the first thing I do is I make sure that it's the correct patient, followed by the correct date of the study. Sometimes when we do these studies, you have multiple x-rays over several days, and you want to make sure you're looking at the one that was just taken. So those are simple things, often overlooked. I made that mistake multiple times as a medical student and even as a resident. So the second thing I look at is I look at the bony structures. You want to I look at the clavicles, I look at the ribs, I look at the trachea and the spinous process to see if it's aligned. If you look at this chest x-ray here, you can see that the trachea, which is here, we'll go over later, is fairly lined up with the spinous processes, which are right in the middle of each of the vertebrae. And so that lets you know that the patient is fairly flat. Oftentimes, if the patient is rotated in the bed, or if they have a bump under their neck or their shoulder in the operating room, it can skew the perspective of the film, and it could lead you astray in terms of what the true findings are. So those are some of the things that you look at when you look at the bony structures. We're never really primarily interested in rib fractures, clavicle fractures, unless perhaps we're going to put somebody on ECMO through a VV cannula through the neck, and you want to make sure they don't have a clavicle fracture or a displaced rib fracture causing an issue, etc. The next thing that I look at is I look at all the soft tissue structures. Obviously the heart, the trachea, the bronchi, the diaphragm, the stomach, soft tissues in the neck. Even out to the side, you can see subcutaneous air or emphysema out towards the scapulas. The last thing I finally look at are all the lines. And usually, when I was initially starting doing this, I would just jump right in and look at the lines, because that's why you got the x-ray. We just placed a central line. We just placed an ECMO cannula. We just cannulated for bypass. We just put in a chest tube, things along those lines. And so the tendency is to jump right into that and start looking at the thing you just immediately performed. But that's often the mistake you make, is you miss some of the other things that are more important, or certainly could determine the method of your treatments. So with an x-ray, the soft structures, everybody kind of understands the bones. You see the ribs, they're blatantly obvious, the clavicles, the spine, etc. But when you look at the soft tissues, it's kind of hard to determine oftentimes what you're looking at. If the pericardium's been open, the mediastinum's going to be wide, and so you just see this big white blob in the center of the screen. But there are certain things that you definitely want to look at here. And if you look at number one, that's going to be your innominate artery coming down, your superior vena cava, all in that region, which continues into number two. And then number three on your right-hand side of your screen is going to be the knob or the arch of the aorta as it makes that curve and heads posterior and then down along the vertebra down into the abdomen. Number four is what we would call kind of the left lateral border of the heart, or the upper mediastinum. And just below that, you see the pulmonary arteries and the veins. 7's going to be essentially around the left ventricle. And that's the area when they talk about inside the box with the gunshot wound to the chest, etc. Right ventricle, left ventricle, those are the structures that can be injured. And I've seen it where they have a gunshot and you're going into the OR, put them on bypass to repair a cardiac injury, and you see the bullet sitting there posteriorly in that section. And so that can help determine where you want to start your inspection in the operating room. Number 8, moving down towards the subsegmental pulmonary arteries and pulmonary veins. 9 would be the right lateral border of the heart. 10 is just kind of into the lung fields where you see the lung parenchyma. And then 11 is down by the inferior vena cava as well as the diaphragm. And then 12 is somewhat down towards the reflection of the pericardium onto the diaphragm and then into this gastric region, which is just below it. This particular x-ray has a couple of different things to look at. We've highlighted here, this is an intubated patient, and the red outline is the endotracheal tube. The yellow outline is the trachea into the left and right mainstem bronchi. There are obviously multiple lines. You see the hyperlucent lines, those are the hyperopaque lines, those are the EKG leads. And then this patient looks like they have some sort of a process primarily involving the left. I would suspect an aspiration or maybe the early stages of ARDS or even a significant pneumonia. But you want to look at everything on there. So identify the patient, look at the bony structures, look at the soft tissues, look at the lines. This is a fairly normal x-ray with the exception of one thing, and it can be very subtle. And so obviously, the more you look at these things, the better you become. You're able to spot certain subtle defects that would be easily picked up on a CAT scan, but you may not always have at your fingertips. So in particular to this patient, we've identified the patient. We know this is the correct one that we've just been at the bedside observing. You can look at the bony structures and do a quick survey. From there you can see that everything is essentially normal. Then we start to look at the soft tissues. I don't really see anything in particular. You can look up towards the scapular region and you can see that there's no air. So if they have a rib fracture, a pneumothorax, perhaps they've had a traumatic crush injury and you're being called in to place somebody on VV ECMO. If you see a lot of subcutaneous emphysema, then of course in your thought process you could think, well, maybe this patient's developing bad pulmonary contusions and that's the reason for the VV ECMO. You can look up into the neck if you've just placed a line and you can see if the line's in the exact place, if it's heading down the normal process or the normal vasculature. The thing that about this, can anybody here discern some of the subtle defects that are in this x-ray? So finally we get to the lung fields. We don't have any lines to look at. That's always the last thing, but to back up one step and let's look at the lung fields. Do you see anything that's abnormal?
I'm glad you're doing this today, but yeah, in the left lower lung, it looks like there's something going on there. I don't know what it would be, if it's a pneumonia or an infection, or whatever it may be.
I want to ask a very basic question about X-ray, and I'm asking a very simple question, but I've always kind of wondered. X-ray is going to pick up the density of what it's seeing. So when we see a patient, who's got really bad lung problems, we see more white. So in this case, I see a little bit more white down in the
left lower lobe.
Yep.
Yeah, right there.
So there's more density, meaning that's disease or that's congestion fluid or something?
Pathology of some sort.
Okay.
So with x-ray, air is white. The more dense the matter, the darker it becomes. So that's why you see the bones light up white and dark. And then out towards the lateral aspect, you could see that the breast are obviously extensive amount of tissue into the latissimus and the musculature and the skin and the subcutaneous tissue. So that's what creates that outline of the body, that it becomes much more bright on the x-ray film. And then the lung fields, and a good normal exposed chest x-ray should be fairly dark. And when you start to see white areas, whether they're in streaky lines or patchy infiltrates or wedge-shaped defects, then that would indicate some sort of pathology. And you obviously have to tie that into the clinical picture. you never want to jump to an assumption, and you always want to take it in context of the patient that you're looking at, because some of these processes can look the same if you're just looking at a plain x-ray. So this is a lady, this would be a classic example of a patient that presents to the emergency room, a couple of days of shortness of breath, maybe a little bit of pain when she takes a deep breath.
What is that black line right there? You see that? Is that nothing, or is that just?
Yes.
I see a pretty distinct line along the.
Along
It looks
the
like it's
lateral,
it's
the left
long-
lateral border.
Right.
I don't know in this projection that it sees anything, but you could see pneumopericardium there. That's where that would show up.
Okay.
Anytime you see an acute interface between white and dark, that's usually kind of an air tissue interface. And so we'll have a couple of other films coming up that will show something along those lines.
Okay.
But more specifically over here, in the left lower lobe of the lung here, you have, I would call this kind of a triangular defect here. Pretty distinct borders. That's going to be a classic x-ray finding of a subsegmental pulmonary embolus.
Oh, really?
And so you get a wedge-shaped infarct where you get lack of flow acutely to the lung, and that's where the shortness of breath obviously comes. You get some inflammation, so you can get the pleuritic chest pain or the pain with deep inspiration. And then you get the non-perfusion of that area of the lung, so it gets congested, full of fluid, and that's why you start to see it as a bright white spot. And so that's just a malperfused portion of the lung consistent with the pulmonary embolus. We usually don't see x-rays like this much anymore just because they're picked up so early with CT scans. They come in with shortness of breath in the emergency room. It's almost always straight to CT scan. And so they're often starting to be treated before an x-ray shows a defect. The defect doesn't show up immediately all the time with chest x-rays. Kind of one of my rules of thumb when I'm looking at patients that are resolving from ARDS, they've been on ECMO and they've showed continued improvement. Maybe their ABGs are looking better. Clinically they look good, but they still have a pretty ugly x-ray. Usually the x-ray will lag behind the clinical picture by several hours, if not a couple of days.
And that works both directions.
It does, absolutely. So this has a little particularly interesting finding here. We can look and see that the bone structures are fairly normal, nothing obvious here, which is very rare that we see it in our line of work, that we see abnormalities with bone structures, etc. Soft tissues. So we've identified the trachea. You can see the left and right borders of the heart. You can see the diaphragm look fairly normal. There are a couple of subtle findings here, and it's something that you alluded to just a few minutes ago. What are some of the abnormal reasons to have an acute interface between white and dark? If you look at the center of this, you can see that there's an abrupt line here, which on the normal x-ray is not normally there.
Right. That doesn't even look anatomical.
No, it doesn't. It doesn't. And you also notice, as compared to that normal x-ray, you have what appears to be some air and solid material interface as well. So this is somebody with a large hiatal hernia that has stomach within the chest. The hernia defect is going to be usually central in portion around the esophageal hiatus. The stomach has slipped up into the chest, and this is just an air bubble within the stomach. This is going to be colon that's up under the diaphragm. Normally this is where you would see the gastric bubble, the spleen, they all live in this area, not colon generally. So that's one of the abnormal findings you would see with this, and this patient could probably come in with chest pain. They've been worked up for myocardial infarction, they've probably had a CT scan for possible PE because of the pain, etc. And they have a hiatal hernia. This is a little bit more consistent with what we see clinically, with what you guys
ECMO.
do and what I do.
ECMO.
Can we get this guy off?
Call Stephanie. Stephanie, she didn't approve my meeting. ECMO.
This is what CEUs would obviously teach you to understand and identify. So Patrick, when you look at this film, can you kind of just walk through what you see?
I'll do my best. I see a lot of problems with the lungs on both sides. I see the placement of EKG leads. I can't see the heart much. I can see a little bit of the heart looks larger than normal. Is that correct?
Mm-hmm.
Okay. That's about what I see. That's why I'm here.
So going through the years of the academics that I did, you learn to identify issues when you're initially sitting down to look at x-rays, and it's just a matter of repetition. So the first thing, again, I would do is make sure it's the right patient. We can skip that, everybody knows. Bone structures look fairly normal. The soft tissue structures, everything looks fine. I don't see a hiatal hernia. I don't see air under the diaphragm. I don't see anything along those lines or signs of trauma. Then the lung fields, which you described, you have this big fluffy cloud pattern on both sides involving all the lung fields, which means this is a process involving all of the lungs. So you would not think in this setting this patient has a massive pulmonary embolus, something along those lines. You would think that this is more of an interstitial or a lung parenchyma problem. And then so your differential diagnosis is going to be pneumonias, aspirations, ARDS, could it be COPD, those sorts of things. And so then you just start to describe what you see to better refine your list of diagnoses. And so this is a fluffy white pattern involving the upper and the lower and the middle lobes of all the lungs. I don't see big fluid collections down along the diaphragm on the sides here, which you would often see. And so this would be a picture consistent with an ARDS, okay? And then obviously there are different causes of ARDS. They can be because of a pulmonary embolus. They could be because of heart failure. They could be from a viral pneumonia, bacterial pneumonia, a chemical pneumonitis from, say, aspiration, those things.
I have a question. Is this patient intubated? Is that what I see in the trachea there? The dark area?
So this is certainly the trachea, yes, and you can come down and you can pick out this is going to be the right main stem here, this is going to be the left main stem here. I do not see an endotracheal tube in this patient yet.
Okay.
You certainly have EKG leads that are there on both chest walls, but this patient is probably about to be intubated.
Okay.
This is another representation of kind of what we just talked about, and it can show the heterogeneity of ARDS. And ARDS can begin in one side or one lobe and progress based upon the physiology and the anatomy of the patient, but it is a diffuse process generally. And so sometimes people could look at these x-rays and say, oh my gosh, this patient is in fulminant heart failure. They have congestion, and so their plan is to start aggressively diuresing this patient, which would be a delay in the appropriate treatment. So it can be subtle at times, and to the untrained eye, you can make a fatal mistake there. But this is classic ARDS, not pulmonary vascular congestion or an exacerbation of congestive heart failure. This is a patient that does have some vascular congestion, and it can be subtle to pick out, which is why it's always important to take this in the context of the patient that you're dealing with. If this is a 16-year-old kid that comes in, this may be just related to the poor technique of the film. If this is a 75-year-old lady with a known history of coronary disease, diabetes, frail, has got a depressed ejection fraction, then the findings become pretty obvious. And what you see that's different with vascular congestion versus the ARDS is that you start to see these kind of lines, this cephalization of vessels, where you see these little white hazy streaks that kind of start to emanate from the hilum and go down. Down here in the lower lobes, it's a little bit more apparent. You see this kind of patchy stuff, but it forms, if you close your eyes and imagine, little lines, and that's just the edema in the vasculature. So this would be vascular congestion, fluid overload, CHF exacerbation. So if you compare, it's obvious in these. This is an extreme example of somebody developing ARS or a diffuse interstitial pneumonitis, inflammation, etc.
And so that big heart, go back to that, what you said, Patrick was commenting about that. You've got that, down at the apex, big heart. Is that predominantly just from pulmonary hypertension, right heart failure, or right heart dilatation?
It can be. So what causes a wide mediastinum or an enlarged heart?
Dissection, I mean.
You could have dissection, yes. You could have a large pericardial effusion.
Yeah.
You could have just cardiomegaly from long-standing CHF. If they dilate the ventricle, obviously over time the pericardium will accommodate. You could have a bleeding issue from a dissection, a perforation, a rupture, things along those lines. But given this setting, this is probably an elderly patient that's got long-standing heart disease, has developed ARDS, and the cardiomegaly in and of itself is significant, but you have to put it obviously in the context of the patient that you're seeing. They may have had cardiomegaly for years, and it's been asymptomatic.
So it's not necessarily.
So it's not necessarily an acute thing. Oftentimes, cardiomegaly or an enlarged heart shadow is not an acute process because the pericardium, as we know, is a confined sac, and it's pretty fibrous in its nature. And if you have an acute process that puts fluid there, they're going to come in because of tamponade rather than just an enlarged mediastinum or heart. The other thing I want you to notice on this film, excuse me, is that you have air fluid level here.
Oh, fluid level. That's below the diaphragm. Well, the diaphragm looks flattened there.
The diaphragm does look a little bit flattened there. And that's likely because they have some COPD changes, which it looks like they do. It's kind of hard to see the projection here, but they probably have some COPD changes, which causes the diaphragms to flatten as the lungs hyper-expand to accommodate the COPD changes. But given in the context of this patient, if I were to tell you this patient came in acutely with abdominal pain, epigastric pain, and you see that plain film there, you could think this is free air under the diaphragm. Therefore, they may have a perforated ulcer in the duodenum or the stomach or something along those lines. If they tell you they've been retching and vomiting and their x-ray starts to look like this, and then they also have that air fluid level under here, of course, you're going to want to start thinking about they're going to develop a chemical pneumonitis because, like we mentioned earlier, the chest x-ray will often lag behind the clinical picture. So if they continue to deteriorate from a respiratory standpoint, you may want to initiate VV ECMO or something along those lines earlier rather than later because you know the process that's developing. What do you think is going on with this picture?
Oh my God. I know what that is. Anesthesia gave too much fluid.
This is definitely anesthesia's fault.
Well, I don't know. It looks like there's dispersed fluid everywhere. I can't see much of the heart. I can see a little bit of the right side of the heart, which looks large to me at first glance. And there's no real clear outline of the lungs. So I'm going to take a wild guess and say this would be more of an edema situation. Am I correct?
Well, I think it's pulmonary edema, but I think it's because the heart is stuffed. So let's see. So stump the chump, okay? So let's see.
So I mean, I think
Am I the chump?
It wasn't.
See, I'm the chump too.
Okay.
We're bilateral chumps here, okay? So what is it, doctor?
So you're exactly correct. And it's and it is not a random guess. You made a very educated guess. You were just, I asked you what you saw and you started to describe what you see. And oftentimes that will lead you to the answer. So you don't have to look at this and pontificate and rub your forehead or your chin and say, this patient is fluid overloaded, they have pulmonary edema.
I would have ordered.
It doesn't have to be that complicated. But
Yeah.
what you described is exactly correct. You don't see the heart borders very well. Why is that?
Because there's stuff blocking it.
The pulmonary hilar get congested, full of fluid, and so they become a lot more white on the x-ray, and so it blurs that distinctive line. You see that the heart is huge, so this patient probably has long-standing congestive heart failure, dilated ventricles, which lend themselves to CHF exacerbations. You also see the cephalization of the vessels where you see the streaky lines kind of radiating out in the kind of a starburst pattern into the periphery. You don't see large pleural effusions, which oftentimes CHF patients will have, but in acute vascular congestion situation, they may not have developed yet. So you're exactly right. You can see that the trachea is midline. You can see the right main stem. You can see the left main stem here. And then you can see these hard white lines right here, right through here.
Yeah, I didn't
Could be fluid that's beginning to accumulate in the fissures of the lung as well. And so, given enough time and sitting down and just kind of writing down your thoughts on a piece of paper, you'll come up with a diagnosis most of the time. And then obviously you put that in the context of the patient. This one's a little bit different. Some of the same processes we've described, but presented in a different way. And so I can tell you that the etiology of this process is going to be a little bit different. So again, Patrick, describe what you see in this film.
Okay, the lungs look pretty, I don't know, the right lung, I'm really stumped on this one. What do you see, Joe?
Just talk about it. What do you see? So the method I go through, again, just for you guys at home, write this down and stick it on a note card and put it in your pocket. And every time in the OR, they pull up an x-ray. If you're at the bedside in the ICU running an ECMO circuit and they pull up an x-ray, I look at the bone structures, normal. I look at the soft tissue structures and describe what you see in the soft tissue. Mm-hmm. I think that if you take a stepwise approach every time, you don't get overwhelmed with everything that's going on.
Yeah, I was going to say, we had a whole show on checklists just a couple weeks ago, and it sounds like you have a mental checklist for sure that you start with.
You asked Joe to go, hey, Joe, go start your plane up. Let's get out of here.
Yeah.
To me, that's really overwhelming. I don't know where to start. And so what do? You pull out the checklist and you run the checklist. And then once you run the checklist, everything seems to work and a miracle has happened.
And even then,
check the fuel gauge.
Check the fuel, yes, check the fuel. I knew that was coming. Okay, so do I see that same wedge in the right, like middle lobe, where that it's a pulmonary embolus?
You're talking about this opacity here.
Yes.
I noticed that too, but I couldn't tell if that was
Is that
vascular
that
or if that
thing
was
that you were talking about, or is it something else?
So let's back up. Let's start with the soft tissue structures. You want to jump to the pathology, and I think that would probably be a mistake.
Okay.
And so let's talk about it. We see the trachea. You see the trachea coming down the midline. You see the right main stem. You can see the left. The left main stem coming down there as well. And then you see the heart border. You see the right heart border fairly well. You see the left heart border fairly well. You can see the diaphragm here. You can see it here, just underneath the breast. This line here is just simply, you have the liver behind here, which is obviously a dense structure. You have the diaphragm, and then you have the breast. And so I think that this interface that you see here, that oval-looking portion is just tissues overlying each other. So I don't think that that's anything of significance.
What are these two kind of bright structures? Let me just point for a minute. You see that one.
EKG pad.
You think that?
Yeah. So those are the clips that attach the EKG leads to the patient.
Oh, okay. There's just no wire.
So
on
the
them.
balloon pump leads, et cetera.
Okay.
Yeah, that's it. And you can see the wire. The wire is running straight here.
Okay, now I see it. Yep.
Here's one over here.
Okay.
So that's that. And oftentimes with these, since these are all digital images now, you can adjust the contrast a little bit, which we can't here. So if you want to start, now we're on the lung fields. What do you see in the lung fields?
No, I see the right lung is congested, the left lung's not. And it's got that one, it's got several areas, but that particularly that one large area in the middle portion of the right lung right there, all I can tell you is it just doesn't look normal.
Well,
So
then I'm curious about this little section right here.
Let's focus on.
You want to start with the left? Okay.
Can we focus on my?
Yes.
Can I have my part answered?
Yeah.
All right, Joe.
I'm getting sensitive here.
You got the baton. Run.
No, I'm waiting for you. That's all I
Oh,
can
you're
tell
ready
you.
for?
Right
Oh, you
lung,
ready to
right
get?
lung,
Oh, okay,
Yeah.
okay. I thought
It just
I thought you were.
doesn't-
Okay.
it just
I thought you were going to
doesn't
say
seem-
something profound, and you're forming the words. No. Okay.
No, I don't need to say anything else and show how little I know about this. I'm waiting for.
No, I think that you're starting to accurately describe the picture that's going on. Obviously, there's a difference between the left lung field and then the right lung field. You could see it's a lot more radiolucent here, darker, meaning it's aerated, normal-looking tissue. And then over here, it's much darker, and it means that there's a process going on. If I were to tell you this is a patient that just got finished with a hard night of partying at the HET conference in New Orleans, and they were out on Bourbon Street till wee hours in the morning, they passed out on the floor and they got sick and threw up their last hurricane. They got short of breath and didn't feel well. They went to the emergency room because they were coughing, and they took that x-ray.
Aspiration pneumonia.
This is an aspiration. Yeah, this is kind of classically what you see. You see it on the right side. You see it preferentially in the upper lobe, which is that defect that you're talking about here. And then you have this diffuse process where your gastric aspirate causes an inflammation of the lung parenchyma. So this would be something along the lines of an aspiration, pneumonitis, pneumonia, something along those lines. See, you got it. You just talk about it. Just describe what you see, and the answer will come forth. So, but we put lines in all the people, everybody. We always do that. In the OR, first thing when we put the patient to sleep, we put in central lines, and we don't use swans as much as we did in the past, but, patients with CHF, and you could see this patient has some obvious cardiomegaly, so they probably have sick ventricle, low ejection fraction, maybe a valve procedure, et cetera. You're going to use a swan. And so the last thing that we always look at are the lines. We've gone through everything else. The lung fields look fine. They may have some effusions because they're in congestive heart failure, and you're going to repair the mitral, et cetera. But we float a swan, and you want to make sure that when you get to the ICU during transport, things weren't dislodged or moved, et cetera. You want to check your line placement. And so you can see the Swan-Ganz catheter coming in. This is going to be a right IJ approach. It's coming down the, what structure?
SVC.
SVC into the right atrium, through the tricuspid, into the RV, through the pulmonic valve, and into the left and right main pulmonary arteries. And so I'm going to flip back to kind of our x-ray that we had earlier. And so you can see where this PA catheter, if you remember your anatomy, you know where you're supposed to look for your lines. And so it comes down to anatomy and physiology. It's never more complicated than that. If you know those two things, you will be right 99% of the time. And so we know that the IJ comes down this way into the SVC, into the right atrium, right ventricle, then up into the PA, pulmonic valve, which is going to be a little bit lateral to where the aortic valve is on the left side, and into either the right main PA or the left main PA. And whether or not you fully wedge the catheter or float the swan or not is kind of an individual practice decision. But I would say that on this x-ray, this catheter is wedged. It's in the sublobar branches of the pulmonary artery, and it's on the right side. So that's the last thing that we look at. This is another good example of an x-ray where the swan is not floated. You can see it's pretty obvious that it's sitting in the right main pulmonary artery. Other things that you could see is if they're intubated, you could see the lung fields, they look a little congested, a little patchy, etc. The diaphragm looks a little bit flattened here, and the heart looks enlarged. Probably 95% of the time, for whatever reason, the PA catheter ends up on the right side. And so it can throw people off if they're not used to seeing it, or multiple films. It can go into the left. And I think that's just because if you look at the PA catheters, they're curled up in the box that they're delivered in, and so they have a natural tendency to sit that way. And so they oftentimes just go off to the right. But this is a perfect example of a pulmonary catheter that's in the left side.
Does that matter clinically? I mean, the pressure would be the same, right?
No, the pressure should be the same unless they have some anatomy on the left side. If they have a pulmonary embolus on the left side, you obviously shouldn't be putting pulmonary catheters in those patients. But if they have a large effusion on one side and their mediastinum has not been open or their pleura has not been open, they could have some slightly elevated pressures. But I think it would be very subtle and it would be difficult to pick up, and you wouldn't really have any way of knowing unless you have simultaneous measurements of the other side.
Right.
So I wouldn't think that
And
it
can
matters.
occlude. You would have to wedge it, wouldn't you?
You would.
Otherwise,
Yeah.
it's because
Yeah.
it's a closed system, so
Yeah.
it's going to pick up both sides,
Yeah.
whatever the higher pressure is.
This is a catheter in the red tip here. This is the pulmonary, pulmonary catheter heading straight out. And I'm not sure what they're pointing out here with the blue arrow. I think that in this projection you can't see it, but it takes a coil in the atrium as well, which you obviously want to avoid.
Yeah.
You don't want to tie it in a knot. So, this one's a little bit different.
Have you ever sutured a swan in?
I have, but I caught it before we left the OR.
That's
I did. I always check it.
That's how-
I distinctly remember, it was a mitral valve repair. We ringed the tricuspid. So normally I would have gone through Sondergaard or Waterston's groove and opened the dome of the left atrium. Instead, they had bad tricuspid insufficiency, so we ringed it. So I had to go through I did a transatrial approach and transeptal approach. And the swan catheter was already in there. And just simply taking out the cannulas and closing up our hole in the atriotomy, I caught the swan. So one of the last things I always do is I always pinch that just to make sure that catheter is mobile and it's not involved in the suture line. I've heard obviously anecdotal stories. I've had one of my mentors had to take a patient back to the operating room to reopen the sternotomy because the PA catheter was sutured in place. So it
Can't blame
happen.
perfusion for that.
No, you can blame anesthesia though.
Yes,
Okay.
you can always blame anesthesia. You can always blame anesthesia. That is the perfusion mantra.
So Patrick, this is a good film where the EKGs are not really obscuring anything that you want to see. And so you can look at the bony structures, you can look at the lung structures, and then we'll just skip to the end and go straight to the lines. And so you can see that this patient is not intubated. They don't have any central venous catheters that I can tell. They may have something in the groin. Mm-hmm. But if you look at the mediastinum, you see something that's unusual. And because you did a diligent job of moving all the lines and stuff out of the way, not to obscure your lung fields, you notice that you see this little thing right here. What do you think that is?
Did someone leave a needle?
That's a good question. I've seen that. I've been fooled. The patient was laying on a cap to a syringe, or they had something radio opaque sitting behind the patient, a foreign body of some sort, and it looks like they've swallowed something, or they've been shot and we haven't found the entry room in a trauma situation. You know, bullet entry can be easily missed, but that's not what this is in this case.
Okay.
Joe.
It does. I will take one more guess. I'm not going to guess what it is, but I'm going to say it's not. It's a foreign body.
Sure.
For sure. Okay. Go ahead, Joe.
It's the tip of a balloon.
It is.
Oh.
And so,
Yes.
All right. Now it makes sense.
and so when we get to the ICU, you know how this works. Everybody crams in the elevator, takes the ride up to the ICU, and then everybody gets everything plugged in, and we're chomping at the bit to start cleaning the room and get our next case going. But we sit and we wait and we wait and we wait and wait for X-ray to come, and they shoot the X-ray, and then we look at it. And this is one of the things that we're specifically looking at. What is the position of the balloon pump? Because you know as well as I do, that's one of the easiest things, dislodged, moved, etc. during transport of a patient. You know, most common places when you're taking them from the operating room table to the ICU bed. That's the most common way for these things to get caught, pulled, tugged, etc. And it doesn't take much. You know, a centimeter matters. And so in the operating room, you know, we obviously put the transesophageal echo down. We're running the wire up. The anesthesiologist is able to see the left superior, the left subclavian, and we're looking at the takeoff there and where the wire is in the tip of the balloon. And then we know the balloon pump is in roughly a good position. If you notice, some surgeons, before they put the balloon pump in, they'll take it out and they'll hold it up on top of the body to kind of get an idea where the knob of the aorta is and where the balloon tip should be. And they kind of take it along the patient and they look at where the area on the catheter is that is
Right.
at the end of the sheath. And so you have kind of a rough idea where you need to start. So you can send the balloon pump up the artery until it's at about that position, and then you start looking for it on the echo, et cetera.
So is this one in a good position or a bad position? Explain what you see there as far as.
Yeah. So what am I looking at when I look at this picture? So obviously I look at the lines are the last thing, and I don't see any central lines. And so this patient has a balloon pump in. And so if you remember the anatomy, you have the number 3 is arch of the aorta, and the things that come off the arch, you have your innominate, you have your carotid, and then you have your left subclavian. And so the left subclavian is going to be the last thing coming off, the thing closest to the arch, the distal aspect of the arch over on the left side. And so if you close your eyes, you could see that vessel coming off here underneath the clavicle and down to the arm. And so obviously you don't want your balloon pump inflating and deflating at the origin of that, because you can cause some ischemia.
Yep.
You can cause the vertebral artery to go down or send thrombus if they have some atheromatous or calcific disease there. If you've just done a lima to LAD anastomosis on your cabbage and they have a balloon pump for postcardiotomy syndrome, then obviously you could cause some damage to that graft or hinder the flow in it. So you want to have it just distal to the left subclavian artery. And in here you have the arch coming around. This is going to be the descending thoracic aorta, and you can kind of imagine that it's kind of going here and hugging the spine down into the abdomen. And so that vessel should be coming off right here. And so you want the tip of your balloon just below that, not to impede the origin of that vessel. So this balloon is appropriately placed. Some people will measure, they'll say it needs to be at the second intercostal space, etc. And that's where you get back to the thing, one of the things we talked about earlier with the technique of the film. Do you see the spinous process is straight up and down along the spine? Is the trachea lined up with that, or is it off to the side? Is the patient laying flat and the x-ray is exactly 90 degrees perpendicular to the patient? Or is the patient slightly sitting up in bed and the technique of the radiologist or the technician is such that the projector is not exactly perpendicular to the patient? And so that can skew the way that it looks. So if you can imagine, if they're coming at this angle, the patient is here, it's going to close those rib spaces, and it may look like the balloon pump's actually higher than it is, or the vice versa is true, or even rotated. And so you have to take all those things into account, and that's why when I go through the x-rays, I go in that exact order. Because if the bone structures look weird, or the spinous processes are not lined up, I've got that in my mind that when I start to look at the soft tissue, the lungs, and the lines, then that can affect what I see there. And so that's why I go in that order. Different people have different orders. If you ask a radiologist, they'll have their own specific way, but that's how I do it.
Well, this lady looks like she's got, it looks like a lady. And, it looks like her right arm is up. She's got a pretty scrunched little neck. She's probably a little, she might be a little overweight.
Yes, and that would be noted in the soft tissue portion of the exam. But yeah, this would be somebody that you would be concerned about their anatomy's a little bit skewed. But you know, I think this is good technique. I think this is a good exposure, meaning you see all the structures appropriately. And I think the orientation of the patient is very good. The diaphragms are nice and even. The lung fields are fairly symmetric. You see that the trachea is essentially midline down the center of the spine. It's not rotated. The other things you could look at are the heads of the clavicle, and then also over here in the humerus and the scapula, how those things can look a little bit different if it's rotated. So those are all the things that I look at, and so I can safely say that this balloon pump is in an appropriate position, and this is a good quality x-ray. And this is just a diagram of where you would expect the course of the balloon pump to be. So obviously, this patient has had a cabbage, and this is balloon pump is
High.
in the aorta. Yes, you can see that it is. You see the course of the aorta. That's where you expect the balloon pump. You see the sternal wires are in place. The patient obviously looks like they have some vascular congestion. You can see the endotracheal tube is in. I would say that this endotracheal tube is a little high because from where I'm sitting, the carina I see is essentially right about here. It may not be quite so high then. And then you could tell that the balloon pump's in the appropriate position. You could see that the Swan-Ganz catheter is in the right main PA, or even actually in just the distal main pulmonary artery. And so this is a pretty typical post-op chest x-ray in a patient that's had a cardiotomy and has a balloon pump. And this just is just a simplistic diagram of showing you where the balloon pump should sit. I think important things to note on this is if the balloon pump is too high or too low, you start to impede upon the vasculature that comes off of the aorta. If it's too high, I think we talked about, it's going to be the left subclavian that's going to be interfered with. If it's too low, then you start getting into the visceral vessels, okay? If it's below the diaphragm, you have your celiac artery, then you have the superior mesenteric artery. So if you have a balloon pump that's placed inappropriately and it's too low and you're trending lab results for whatever reason and you see that their LFTs are going up or that their creatinine is worsening even though they have all other indicators of good perfusion, you can look at your balloon as one of the sources of the problems. And these things are not benign. These are inflating and deflating in an aorta that may or may not have disease. So if you have some atheromatous disease inside the aorta and that balloon is just pounding away at it, you can see how small portions of that could break off and become emboli. Perfect timing of this film. So this is obviously somebody who's had a cardiotomy. You see the sternal wires. You see the lines that are in place. This patient has a balloon pacemaker in. These are some leads here. And then this has a balloon pump. And so
that's the tip. Where's the tip? Right where the arrow is?
This is the tip of the balloon here.
All right.
But this would be a perfect example of a tip that is extremely low. So this is probably somebody who's not used to putting balloon pumps in, putting a balloon pump in.
Scared.
And so this would be somebody, this balloon pump may actually be inflating and deflating well into the iliacs.
Wow.
So that would be quite a red flag. So if you get your x-ray and you don't see the balloon pump lead or the tip of the balloon pump in there and you know you just placed a balloon pump, get a KUB. Another example of a balloon pump that looks to be appropriately placed. This one's slightly different. This is a little stump here. So,
see if anybody's gonna ask on here. I'm gonna put it on here. I'll put it on the chat. What do you think?
So anybody at home dialing in?
Roger? Hey, you want to open the, send a message out, open the phone lines? Let's see if anybody wants to call in and guess at what the problem is with this last x-ray. So it'll take about 20 seconds or so before, and I'm watching it here, so I'll know when the people at home actually see the message. So these are really interesting x-rays. I'm looking forward to the TEE. But and the CT. The CT, this is, I mean, you don't realize how much you don't know until you learn what you don't know. It's x-rays, you see them all the time. So while we're waiting for this to come up, and I'll monitor it here, I did a case, and I know Chuck DeCourty is probably not watching this program, but maybe I'll send a link to him and he can watch this another time or later, because we always put all of our videos on YouTube permanently after the programs. But sometime prior to this procedure that I had done, keep in mind this is going back a lot of years when you could get away with this kind of stuff, and but. Another surgeon had left a bulldog on the circ graft and had to take the patient back to remove the bulldog. And as you can well imagine, it was the talk of the town. It was the talk of the town. So him and I did this case together, and it was a 4-vessel coronary, and patient was doing just fine. And The routine was they would take the patient, do the X-ray in the OR, and then take the patient to the ICU, and then the X-ray would come and put it on the view box in the back between where the ICU nurse's station was and where the coffee machine was, or the coffee pot. So Dr. DeCordy left, and I told the guy, I said, I need you to take 2 X-rays, okay, if you don't mind. And he goes, yeah, sure, Joe, what you need me to do? I said, okay, so take the good one. Don't get them mixed up, though, okay? You got to take the good one now. They took the good one now, and then I took 2 bulldogs, and I placed them on the chest in various positions, and he shot the second film. I said, that second one is the one I want you to put up on the view box. So he said, okay, no problem. So we were sitting there, we were having a cup of coffee, whatever, and he came by and he said, Dr. Cordy, X-ray's up. He goes, oh, okay, thanks. I'll be right back, Joe. So he left, and he came back, and he just was white. He was white as this sheet of paper that you have right here. And I said, what's wrong? He goes, go look. I mean, I just can't believe it. So I said, go look at what? He goes, just go look at the X-ray. So I went back, and guy was there, and I said, switch it. So he switched it for the good one, and I said, X-ray looks fine. He goes, Joe, you're blind. So, walked back there, and he looked, and he goes, what the hell? What the hell? I ran, we laughed and laughed and laughed, showed him the second X-ray. He was none too happy. Okay, anybody get a call in? I don't see the thing come up yet, Raj, on the...
It came up.
It did?
Uh-huh.
Oh.
I took it out already.
Oh, you did?
Yeah.
Oh, okay. All right, well, let's just keep going, and then
All right.
hopefully somebody will call in.
So this one is a good film. This shows a lot of different things. And so if you look at the bony structures, they all appear relatively intact. I don't see any bad fractures or anything like that. So let's move on to the soft tissues here. And then what you can see here is when you look out here, you do see subcutaneous air and emphysema here. These lighter areas that are within where the latissimus and the chest wall are is subcutaneous air, emphysema. So this patient probably has had a traumatic injury, or they've had a line insertion that went bad or something along those lines.
Anesthesia, again.
Again, that's anesthesia, and the surgeon has fixed this. And so this patient came in respiratory distress, they got intubated. So now we're starting to look at these other midline soft tissue structures, and then the lungs, and then we'll get to the lines. So there's obvious discrepancy between the left and the right lung fields. This one is very, very, very dark. This one is very, very, very white. So there's something going on preferentially between the left and the right lungs. Which one is normal? Which one is abnormal? Are they both abnormal? And if so, in what way? And you can look at the endotracheal tube as it comes down the midline. And this patient, you could tell, is a little bit rotated. This is the trachea, but it is off the midline. So this patient's head is likely turned towards the left side, or he's also slumped down in the chair a little bit, or the plate behind the patient for the X-ray is not situated appropriately. So this is marginal technique. You also can't see the lower portion of this lung field here. So this film would be insufficient from a technical, classical sense of being a good film. But you see the endotracheal tube coming down, and all of a sudden it takes a hard left turn into the left main stem. So this patient is left main stem intubated. That's why you see all of this here, and then you can see you don't see any lung markings over here. This is fairly dark and therefore full of air, and you don't see any lung markings whatsoever. So this patient has a pneumothorax on this side. This is a chest tube coming in here, but this lung will never re-expand until anesthesia gets the endotracheal tube out of the left main stem and starts oxygenating the right side. So a lot of different findings on this one. But if you go in that stepwise manner, you can start to put the picture together. You can imagine if you're a radiologist sitting there in a little dark room with your cup of coffee and your little, your mood lighting and everything like that, looking at X-rays. You can start to figure out what's going on with this patient just by looking at the X-ray, going through these steps every time the same way. This would be a great call-in film if anybody's able or available to call in. Describe what you see here. This is worth bonus points.
People don't want to. They don't like to call. They get
nervous?
They get nervous.
Okay, well, let's put Patrick on the spot, see if he gets nervous.
We have all these people. Somebody call in. Okay, Patrick, you're on the spot. Yes, I like putting Patrick on the spot.
You're supposed to say the lines are open to call in.
The lines are open to call in.
Long-time listener, first-time caller.
Well,
Did they
I'll
win
tell
a
you,
prize? Did they win a prize?
Yeah, they probably get the CEU credited to them.
You mean
I'm going to start with the.
you will get a prize. I'm not saying what the prize is. Prize will be a surprise. It's a surprise. So call in. If you call in, there'll be a surprise.
I'm going to start with the process that you've been talking
Okay.
about. Let's talk about bone structure, and I don't see any damage to the bones. I don't see any
Good.
anything interesting there.
Correct.
To me, the heart looks slightly enlarged. Pretty much enlarged. So we have somewhat some congestive heart failure.
Okay.
The lungs look pretty good to me, but I see two things that step out. One is that I don't know what that is.
Mm-hmm.
And then there is this outline of a very dense piece of something that I don't
Very
know
good.
if that's
Okay.
a line or what. I also don't know what that entire mass is now that I
Sure.
think about it.
Okay, so that's good. So, yeah, this is a good X-ray. This is it could be a little bit wider, see all the way out to the end of the chest wall on either side, but this is a good film. You can see that yes, the bone structures are in fact normal. This pericardium could be a little bit enlarged. It also seems a little bit elongated. So this is probably a tall, thin person as well. The diaphragms are not flattened. Oftentimes you can see the diaphragms flatten in somebody with COPD or emphysema, and that will stretch that mediastinum, and therefore the cardiac silhouette's going to be elongated rather than kind of boot shaped like you would see in somebody with a CHF.
So that's a good, healthy diaphragm, right?
So yes, this is a good healthy diaphragm. So we're moving on to the lines here. We see the endotracheal tube. It stops right here, and you can see the left and right main stem here. So this is just a centimeter or two above the carina, which is where you want the endotracheal tube to be. This, I know just from experience, this is going to be a defibrillator pad most likely.
Oh, okay.
And so this is somebody who probably came in a code situation, maybe had a shockable rhythm. They had the pads on them for defibrillation. And the other one may be way down here. We just can't see it, or it may be out here on lateral on the chest wall, inappropriately placed. But this is also a balloon pump, and this balloon pump is obviously too high.
Yeah. Okay, I thought it would look like a balloon pump.
So you really
but
get two
I thought it was
choices
still-
as to where this balloon pump is going. It's either going in the carotid on the left side, or it's going in the left subclavian. And based upon where this is headed, this is probably going into the left carotid. So this person may not wake up very well if,
Yeah.
in fact, this balloon pump is functioning.
Wow.
Second verse, same as the first. What do you see here, Patrick?
Is this a pediatric? This is a X-ray from posterior.
All right.
This is not something I can comment on. This looks crazy to me.
So let's go through it and the way we talked about bone
Yeah.
structures.
So bone structure to me looks completely. No, I don't see any fractures or anything, but it looks different to me.
Okay.
It looks like maybe I would guess this could be a posterior X-ray, maybe.
Well, in general, these are going to be AP films.
Okay.
And that means that the X-ray is coming anterior to posterior. The patient has the plate behind them, in between them and the bed usually, and that's
Right.
an AP film. Okay.
So the things that jump out to me are that we definitely have a difference between the right side and the left side as far as the density. So, but it doesn't look like a lung. I see no outline of a heart at all. I see no outline of a lung. So I guess this is a edema situation, but only on one side. It's a very odd X-ray.
It's a very odd X-ray. A lot of different things going on. You see the patient's arms are above their head. So you mentioned that the bone structures look abnormal to you. You see the clavicles are rotated up because the arms are above the head. So
Okay.
it looks a little bit different from that perspective. You can see that there's obvious difference between the left and the right lung fields. This lung field on the left side is nearly completely opacified. That's either lung tissue or it could be the heart as well over there. And then on the right side, you see not much of anything at all. You see some lung markings up here in the upper portions. And then so we get to the lines. We don't have any central lines. These are going to be EKG leads. But you have the endotracheal tube that goes all the way down
Okay,
into the right side. So this
Okay.
patient is right main stemmed. And this could be a tension pneumothorax from a massive pneumothorax caused by either they primarily came in with that, or oftentimes you could see that if they get right main stemmed and you have a respiratory therapist or a resident or a med student that's very aggressive with the bagging, you could cause an iatrogenic pneumothorax. Mediastinal shift because of the tension pneumothorax. And so you don't see the heart border here on the right side because all this is such under such extreme pressure and tension, everything is on this side. Okay. So the corrective steps would be, number one, do a needle decompression or an emergency chest tube to this side to relieve the tension, and then withdraw your ET tube to better ventilate and oxygenate both sides. And so this can be completely collapsed, or this becomes opacified from mucus plugging, et cetera, which causes the consolidation in the left side. And this is the one that you're going to be primarily trying to tease out when you're in the ICU. You've got your patient in from the ER, from the OR. You've initiated ECMO, and you have your venous cannula in the IJ.
Now, these next two films are actual films of Patrick's patient.
Yeah, I was
Patrick
trying to.
sent me this one and the next one, these two X-rays. So it's so go ahead. But I want to let you
This
know these
picture is
these
why
are
we
actual
started
cases.
this topic.
Yeah, this was
because I
the
realized
nidus
I
for this
can't
whole
read these
Started
very
this
well.
whole thing exactly.
Yeah. And what am I looking at? And if you're not used to looking at these, or if you don't have a systematic way of looking at this thing, this is a very overwhelming picture. You have no idea what you're doing. This is kind of a Where's Waldo? You're trying to tease out some things, and you're going straight for the gold, but you miss all the other glitter that's around it. So this is obviously an intubated patient who's been initiated on. We know that the patient's been on ECMO, and so the important things when you know all this, you're not trying to guess what's going on, is how are my lines and my cannulas, okay? And so the things that we're looking for are central lines if they have them, endotracheal tube if they have them, but most importantly for you guys that are at the bedside handling these sorts of things or initiating ECMO and worrying about your flows and et cetera and your oxygenation status, one of the things you check is your cannula position to see if everything is okay. So this patient has one of the Avalon cannulas in the IJ, and a couple of things that you want to look for are where are the two tips, where's the side port and where's the distal tip, are they in the appropriate place, and therefore is the cannula functioning properly. And so
Where is the atrium? That's what I want to know.
Yeah, that's exactly right. And so if you don't know the anatomy, then you don't know what you're looking for, and you don't know what you're looking at. So you can see in this picture, this is the knob of the aorta coming up and coming around. This is the left heart border. This is the right heart border coming down this way here. And when you start to have structures on top of structures, it can blur it a little bit. And this is where it's nice when you have a digital image, you can mess with the contrast and invert the image, et cetera, to help see those subtle things. But you can see that this is the Avalon cannula coming in down here. It's in the right IJ, you know that because you put it in. And then you advance it over a wire with either fluoro or TEE, so you have it in the right position, so you know it's coming down. So you know that this is the superior vena cava here, coming down. And where the vena cava meets the heart border is usually the right atrium SVC interface, okay? And so you know that it's coming down, and what you want to look at with this Avalon cannula is you want to make sure that that tip of the cannula doesn't take a hard left turn into the atrium or into the right ventricle, because I have seen an RV perforation from this type of cannula before. And so you want to make sure that
That's catastrophic.
Yes,
Yeah, I was thinking that would be
patient
bad.
did not survive. And so you see the tip of you see the outline of the cannula coming down, and it's going into the IVC here. So generally, if it's going to go into the atrium and into the ventricle, that's going to happen up in this upper portion here. Okay.
Now, is the IVC on an X-ray like this going to be inferior to the dome of the diaphragm? Or is it going to be above it? I mean, I'm assuming, of course, well, I'm not assuming, I mean, I know the liver is right there, but, you know, how far down to that diaphragm, or does it need to be below it to really be certain you are really in the IVC and not just at the right, at the right atrium? Because that cannula is so placement dependent in order for it to work properly.
Sure.
If you're right at the IVC atrial junction and really not, at least a centimeter or two, a couple of centimeters in the IVC, it's really not going to be an effective cannula.
Yeah, you're exactly right. And so that's where you put it in the context of what's going on with the patient. Are you having good flows? Do you have good cardiac output? Are your O2 saturations looking good? Are the ABGs consistent with appropriately functioning cannula? Are you having problems with flow, chatter in the lines, et cetera? And if you're having those things, then yeah, you could have an inappropriately placed cannula. The other thing about the Avalon cannula is they also have the side port with the marker that you can see as well. So that should be roughly at the right atrium SVC junction, and then the distal tip should be further below, well below. Now, whether or not the diaphragm, where the tip of the cannula should be below the diaphragm or above the diaphragm, depends on the technique of the film, also the habitus of the patient. If they have flattened diaphragms, it may be pushed way down, the mediastinum may be elongated, and so that IVC is in fact above the diaphragm on that x-ray. We know that it's within the pericardium and it's onto the side, and the diaphragm comes around medially and at that area, all at the confluence of the area. So it may or may not be under there on the x-ray.
So let me
And
ask you
generally it
this.
is.
If with that Avalon cannula or catheter, I guess it's a combination, it's both really. If it were not far enough in, if it were not in the IVC and it were in the atrium, would you expect there to be a deflection versus it being, looking like it's really straight down? I mean, would it come up and sort of become more angular, or would it just sort of sit like this above the IVC? Because if you first put it in, yeah, we sort of know whether or not it's working, but the first thing we're going to do is, is the oxygenator working? And if we're getting, I guess we could do a venous saturation and see, but even then, the cannula is still going to have some recirculation to it. The real question is there a way radiographically to confirm, or do you need to do a TE? Is it just going to require this is good to give you a general idea, but it's not going to be specific enough and to confirm that it is actually where you want it to be?
Well, I think the TE ultimately is the best confirmatory study, and that's because you can tell under echo where that jet is entering the right atrium, or if it's entering the right atrium. Is it slightly above? Is it slightly below? Is it posteriorly oriented, et cetera? And so the TE is very beneficial from that standpoint. In general, putting these catheters in, I think you can put the catheter in and initiate ECMO with this cannula without having an echo. And one of the reasons you would know that the catheter is in fact going distally and not sitting right at the atrium, et cetera, is you have your guide wire in place. And when you advance that catheter over the guide wire, you can see that the guide wire is not going into the atrium and into the ventricle,
right.
It's going down the IVC.
That's right, because you have to have that guide wire in first, and because you can see on the x-ray, you're going to put a fluoro.
Fluoro, sure.
So you're going to have fluoro when you put it in. So you're going to know it's in deep enough. Okay, well that's
Or if you're putting it at the bedside and all you have is a static x-ray image, you can always just move the plate a little bit lower and shoot a KUB, and you'll see that wire below the diaphragm in the IVC.
Yeah, I worry a little bit about that cannula. Do you have any experience with the Protect Duo? Have you seen that one? So it's a cannula that Tandem Heart had, that they were selling with their system, and now LivaNova just bought Tandem Heart, or Cardiac Assist, or whatever their name was. They have different names. But it's a cannula that goes percutaneously into the IJ and into the pulmonary artery. So it drains from the right atrium and returns to the pulmonary artery, essentially eliminating this recirculation phenomenon. Now, it's a little bit smaller, but that's a 30, that looks like it's a 31, it probably is a 31. This is down about an 18. So you don't get as high a flow. That cannula there, you can flow 5 liters all day long. This one, you're probably going to be lucky to push 3.5 or maybe 4 tops, but you have zero recirculation. So, do you have any thoughts on which you think?
No, it sounds like that catheter is probably a little bit more finicky to place initially, and it could be fraught with other disasters. You've seen issues with floating something as simple as a swan.
Yeah.
And so pushing that big catheter through maybe a big dilated RV, et cetera, could be quite difficult. I think the Avalon's a great cannula. I think that the key is just the placement. If you can appropriately place the cannula, it probably will provide adequate VV circulation for 99% of your patients. Just that one catheter alone that needs VV ECMO.
Yeah.
But there are some nuances to placing it, as with all these things, and the hardest thing usually is just the logistics of getting the people at the bedside and coordinating all the different players that need to do that. Do you need a cardiologist, or can your cardiac anesthesiologist do the TEE? Can they get that up to the bedside quickly? Can you do portable C-arm on the beds you have? Are they in the ER on a gurney? Or they have to move them to something where you can X-ray through? You can do it with plain films. I mean, everything is kind of institution specific in terms of what you have at your disposal to putting these in. But I think that if you understand Seldinger technique, if you know the anatomy, you can verify that you have a wire going into the SVC, into the IVC. And you have a good plain X-ray where you can delineate the cardiac anatomy, the mediastinal anatomy, the SVC, IVC, heart border, etc. And then you have somebody that's proficient with putting these cannulas in. You can get it in and initiate ECMO and be okay. And then if you're having problems, I think then you could call on different modalities like TEE or even fluoro or something along those lines to better position it. But I think to initially place one of these things, all you need is a plain X-ray. All you need is a plain X-ray.
Well, I mean, I don't mean to sort of be moving the topic away from X-rays to ECMO, but I talked to a fella in Denver, and he was telling me that, and that's at altitude, that they're rotating the cannula, the Avalon, 180 degrees, and instead of having the jet going towards the tricuspid, they have it essentially going up into the appendage. And he says that they're getting much better saturations that way than trying to, finagle this thing so it's actually pointing where you think it's pointing. He said it's not worked for them, and they've just gone to reversing to 180 degree rotation and having the outlet going up towards the appendage. And he said that it's working much better for them. I thought that was odd.
No, that's interesting. I can't really think off the top of my head why that would be better. I don't know how it would be inferior. I mean, as long as you're delivering oxygenated blood into the right atrium, you're efficiently providing VV ECMO.
Yeah, I don't know why it would be better either, frankly. But I mean, that's what he told me. And then my last little vignette, sort of caveat to talking about this cannula is we were changing a system, and we changed all the lines all the way up to the cannula. And for some reason, I disconnected both lines at the same time, and then took the one of the lines out of the access of the return, but I forgot which one was which because they're not marked, and there weren't any more caps on them with color codes. So we had to look it up on YouTube to see which was which, and then I connected it and everything was fine. But just so you know, if you do change one of these cannulas out, change one at a time.
I have one. I've always wished that the Avalon cannula had
I think there's another X-ray too of the same one that he sent me. Yeah, there it is. It's the same
so
one.
this is a close-up. Yeah, this is nice. So it's hard to see, but there. Excuse me. It's hard to see here, but there should be. There's a little marker here where that side port is, and it's hard to see on this projection, but that's what you would be looking for, and that should be, as you come down, the SVC is here. You can see that this is the heart border here, and over here on the right heart border, it's primarily right atrium, and then it goes into the IVC. So if you have that marker, kind of really from about this area down to about this area, you should be in the ballpark of the right atrium and then aiming it towards the tricuspid.
Could we rely, I'm sorry to interrupt, but could we rely on the diaphragm as a marker and say we want to be, one rib above the,
yeah,
at least one
you
rib
can,
above the diaphragm?
but again, it goes back to the technique of the film.
Right.
If
what's the angle and all that.
The angle and all that sort of stuff. But if you have a reliable AP film that is at a 90 degrees to the patient, and you look at that and you see that the clavicles are equal and symmetric, the spine is midline, this is a good film. You can see that the spinous processes are basically straight down the middle, all the way down here, and so this patient is not rotated. So yeah, I think that you see the distal tip here. You have the diaphragm coming down this way, and it ends roughly in this area, and then you see the distal tip of the cannula here.
That looks deep to me.
So this may be a little bit deep. It just depends on this patient has an elongated mediastinum, things along those lines. If you're having good flows and oxygenation, I would probably leave this cannula alone unless you're having problems. And if you're having problems, before I start to mess with it, I would probably drop down a transesophageal echo probe to verify that your jet is heading towards the tricuspid.
And you have no problem with, course, we try to minimize our anticoagulation now. We keep the PTT, the APTT 1.5 times baseline. But, how do you feel about doing that, putting a TEE in with the patient on some level of anticoagulation? Any problem with it at all?
I've not really seen that. I mean, unless they have a pre-existing condition, such as esophageal varices. Maybe, I saw a guy in the clinic who had a neck dissection and some radiation to the neck for cancer. That would be somebody I would be very leery of putting one down if they've had known strictures or things along those lines. If they have a certain medical comorbidity that would complicate that. But I think that necessarily putting it in with an experienced anesthesiologist or cardiologist, I don't necessarily have that problem because the patient's already intubated. So there's only so many places that could really go unless you get off into the sides, into the subglottic space and the vallecula and things along those lines. You could cause some injury, sure, but you can also do it in a direct laryngoscopy because the patient's asleep and intubated and sedated, and so you could actually just stick a laryngoscope in there and directly insert it.
Mm-hmm. Okay, very good. Okay, so we have, believe it or not, we have 34 people watching right now. Nobody's calling in. I don't know why. But Roger, I think what we're going to do is take a short 5-minute break.